Pralidoxime. It is a quaternary ammonium oxime that reactivates acetylcholinesterase inhibited by organophosphate compounds. It is used as a specific antidote in organophosphate poisoning, provided it is administered before the aging of the enzyme organophosphate complex occurs. Because it poorly crosses the blood-brain barrier, its effects are mainly peripheral, particularly at the neuromuscular junction. The clinical scenario: a 30-year-old farmer arrives after pesticide exposure, drenched in sweat, salivating, wheezing, vomiting, with pinpoint pupils. Atropine is given. Secretions dry up, heart rate improves, breathing eases. But one alarming problem remains. His muscles are still twitching. He cannot lift his arms, and his respiratory muscles are becoming progressively weaker. If nothing else is done, he may still die from respiratory paralysis. Why did atropine fail to reverse the muscle weakness? Which antidote can actually reactivate the poisoned enzyme, but only if given before it's too late? The answer is Pralidoxime. Why atropine is not enough? Atropine blocks muscarinic receptors, so it dries secretions such as saliva and bronchial mucus, improves bronchospasm, and stabilizes heart rate by reversing bradycardia. However, atropine has no action at nicotinic sites. The neuromuscular junction is not blocked by atropine, so muscle weakness, fasciculations, and paralysis continue despite adequate atropine therapy. This is where pralidoxime becomes essential. Pralidoxime reactivates acetylcholinesterase and reverses muscle weakness and paralysis. Therefore, the key message is that atropine treats the muscarinic manifestations, whereas pralidoxime treats the nicotinic neuromuscular effects, making the combination life-saving in organophosphate poisoning. Mechanism of action. Let's go through the mechanism of action of pralidoxime in a logical sequence. First, the organophosphate binds acetylcholinesterase, inhibiting the enzyme. As a result, acetylcholine is no longer broken down, acetylcholine accumulates at synapses, and a cholinergic crisis develops. Next, pralidoxime attacks the organophosphate acetylcholinesterase complex. Because pralidoxime has a high affinity for the phosphate group, it binds to the organophosphate acetylcholinesterase complex and displaces the organophosphate. Once this occurs, the organophosphate is cleaved, meaning the organophosphate is pulled away, allowing acetylcholinesterase to be reactivated. With functional acetylcholinesterase restored, acetylcholine normalizes because acetylcholine is once again broken down normally, leading to resolution of the cholinergic crisis, especially the nicotinic manifestations such as muscle weakness. An important pharmacological feature is that pralidoxime has a quaternary ammonium structure. This results in poor CNS penetration, so its action is mainly peripheral, particularly at nicotinic receptors in the neuromuscular junction. Therefore, it does not effectively treat central cholinergic effects. One of the most important concepts in organophosphate poisoning is the aging phenomenon, because it determines whether pralidoxime will work or not. At the time of exposure, the organophosphate binds acetylcholinesterase, but this bond is reversible initially. During this early period, there is a valuable window of opportunity when pralidoxime can still reactivate the enzyme by removing the phosphate group from the organophosphate acetylcholinesterase complex. However, after approximately 24 to 48 hours, aging begins. During aging, the bond between the organophosphate and acetylcholinesterase becomes permanent, making the enzyme irreversibly inhibited. After aging, pralidoxime is ineffective because it can no longer break this permanent bond, and enzyme becomes permanently inhibited. The key message is that early administration is the single most important determinant of pralidoxime's effectiveness. Clinical uses and adverse effects. The most important clinical use is organophosphate poisoning, where pralidoxime is always used as an adjunct to atropine, not as a substitute. It is effective against poisoning caused by organophosphate insecticides such as parathion and malathion, as well as nerve agents like sarin and VX. Its greatest benefit is neuromuscular recovery. By reactivating acetylcholinesterase at the neuromuscular junction, pralidoxime reverses the nicotinic effects of organophosphate poisoning, including muscle weakness, fasciculations, and respiratory paralysis. Common adverse effects include nausea and vomiting, dizziness, and blurred vision. Some patients may also develop tachycardia and hypertension, particularly if the drug is administered rapidly. Let's conclude with the key takeaways from pralidoxime. First, pralidoxime is a cholinesterase reactivator. It reactivates acetylcholinesterase by removing the organophosphate, something atropine cannot do. This is why pralidoxime addresses the underlying enzyme inhibition rather than simply blocking the effects of excess acetylcholine. Second, pralidoxime produces nicotinic reversal. It specifically reverses muscle weakness, fasciculations, and respiratory paralysis at the neuromuscular junction, helping restore normal neuromuscular transmission. Finally, remember the golden rule: give early. Pralidoxime must be administered before aging, which usually occurs within 24 to 48 hours. Once aging has occurred, the drug becomes ineffective. Also remember that pralidoxime is always used as an adjunct to atropine, never alone, because atropine controls the life-threatening muscarinic manifestations, while pralidoxime restores acetylcholinesterase activity.